and we're good to go.
Do I get a countdown or just start?
Start now, you're on.
Okay, well, thank you very much, Jeff. So hello, one and all. I am Don Crane. I am the former president and CEO of America's Physician Groups, and it's a pleasure to be able to join you all today talking about this really exciting opportunity in Jericho Reach. So a little bit of background. So America's Physician Groups, which I led for about 21 years until just last March, has long been a leading advocate of this REACH program. So of course it started with the fact that our members, about 350 groups all across the country, employing and contracting with tens of thousands of physicians, taking care of tens of thousands of patients, have long felt that risk-based models were the best way to take good care of patients and coincidentally, make some profit and pay the bills. So we've had our hair on fire about a REACH. We advocated for it, and now it is here. It is truly an opportunity for physicians to both make better income than they ever have in original Medicare and retain their independence. I strongly think that you should be signing your expression of interest in this program. It is a really excellent opportunity, and looking forward to the Q&A that follows to add some particulars on it. So with that, I'm happy to turn the microphone over to my friend Jack Lewin, who's joined us. Jack, I don't see your CV in front of me yet. If somebody would move the slide, that would be great. So there is Jack's CV. Most notably, he was to me anyway, longtime CEO of the California Medical Association. So we had a chance to work in the same state for a long time, which state was to a certain extent kind of the quote unquote, birthplace of then known as managed care, a model that has evolved a lot until now. As you can see, he's the chairman of the National Coalition on Healthcare, active in a lot of other ways, including being an advisor to two U.S. presidents, president and CEO of the Cardiovascular Research Foundation, CEO of the American College of Cardiology, and as I said, the CEO of the California Medical Association. So with that, Jack, I will turn the phone over to you.
Hey, Don, thank you. And, and Don, I think we actually have been colleagues over the years, and I didn't always have all my members in the California Medical Association totally aligned with what I thought was, as you well know. But, you have been a leader all the way through in moving toward this value-based time that we're in. But here's what's so amazing about this. I mean, I have seen every kind of financial model imaginable, to try to help us improve outcomes and lower costs and move toward value. And it could be bundling, it could be, all sorts of other, different manipulations. And the ACO world, the intentions are really good there. I hope all of you know that the physician-run ACOs have been 7 times more effective than the hospital-run ACOs. So doctors do well when they take the leadership in these kind of models. But there's never really been a model like the ACO REACH that Jericho REACH is now going to try to implement. And I guess here's how I can try to explain it to you. In the past, I mean, we've been trying to manage the Part B costs, the physician side of the costs with our patients. And we've had some other tweaked advantages that we could gain some incentives if we did really well and prevented admissions and ED visits and so forth. But we really didn't have the control of the big model. In this new model, I mean, this is, to take a deep breath, this is startling. Physicians are going to be able to control Part A, Part B, Part C, the entire thing. In the private insurance model, which will follow rapidly behind it, because the private insurers always jump behind Medicare's lead, it'll be inpatient, outpatient, and ancillary care with the doctors in control. So here's what I'm saying. The doctors will be controlling not only all the clinical care, but we will also have, the leadership of the financial management of the entire program. And that doesn't mean that physicians who take on this model can't hire really good people to work for them in the process, to have the talent they need to make sure that they have, and also that physicians can get the data they need to make sure patients aren't heading to the emergency room without you knowing it, et cetera, et cetera. But this new model is really, incredible. Ultimately, I think we see the handwriting on the wall. We're all going to be heading toward value-based care. That's inevitable. Sitting as chairman of the National Coalition on Healthcare, it represents AARP, big labor unions, big business coalitions, some of the large physician organizations out there, and many others who are all kind of worried about the rising costs of healthcare and how is this sustainable? But the value-based thing is inevitable. That organization has been promoting it just like Don's organization has been. But up till now, the models that the government put forward were really not adequate to get the job done. So the options aren't all the same out there. There's still going to be some of the old model ACOs. There's still going to be bundled care management programs. There's still going to be various other kinds of incentive models in the private sector and in the public sector. But this new model, you just got to understand it. This one favors doctors. It puts physicians in charge. And the reason CMS wants to do this is because they've seen, investment bankers and others coming in as the partners for doctors in ACO models and taking most of the money as profits, or hospitals coming in and not even really sharing data very effectively, but taking most of the money in terms of the incentives. This model is really different. And that's why you've got to understand this. And we're lucky to have Dr. Joseph with us because she's run an ACO with the old model and even made that model work. This model is a paradigm shift. It's completely new. The opportunity is unprecedented. And the moment now for doctors to get involved is important because you got to sign up and just put your name in for this by August 4th to just have your placeholder in place. So look at this as an incredible opportunity. I've seen medicine from every possible side, and I think this is super exciting. I'm really excited to be part of this program, Jericho Reach, and I think we're lucky to have the leadership of Dr. Lerla Joseph to help make it really happen at the community level. So Dr. Joseph, we look forward to hearing from you with all of your experience with CV CHIP and all the other major things that you've accomplished in Virginia and elsewhere. But you've already done this, but with a model that isn't anywhere near as good as the new one that we're going to have in January of 2023. So take it over, Dr. Joseph.
Good evening, everyone, and thank you for jumping on this call this evening. I know you're all very busy, and we really want to give you some succinct information about this great opportunity. As Jack mentioned, I started CV CHIP back in 2012. We got our first contract in 2016. It was difficult, primarily because physicians were not aware of the opportunity that they had to put this together. The reason we started CV CHIP was that there were so many things happening in the healthcare system that were not favorable to physicians. Physicians were retiring early. We had just come into this whole electronic health records. There was push by the government to make sure everyone was on electronic health records. And of course, early on, it was an incentive, but we were closely coming on the penalty if we did not have electronic health records and were using them usefully. Hospital systems were literally purchasing practices as quickly as they could because they had already read the tea leaves. They knew what was going to happen. And then there were doctors who were just simply leaving practice because they'd gone into practice to care for people and they felt that they should get proper remuneration for the care that they delivered. But it was becoming more administrative and more frustrating. They had overhead like any other business had. And at the end of the day, they were seeing that things were not adding up for them. So they just left. They had good retirement systems. And so they said, I'm gonna hang up my coat. We also had trouble with contracting with commercial contractors. And for physicians like myself who practice in the inner city, we had some of the most unattractive patients. And so our contracts were often very narrow. We didn't get a lot of the patients that had the wherewithal through their insurance to support the care that we provided for them. We had a lot of Medicaid. And of course, we had Medicare, and many of our Medicare patients were seeing doctors for the first time. They were the sickest ones. So it was just one of those sorts of things that when the accountable care organizations came along, I saw it as an opportunity for physicians to come together where we could begin to collaborate with the care that we provided, but also the population of patients that we took care of had never been adequately managed. And I realized that if we could do some of those simple things, manage their chronic care much better, their diabetes, their hypertension, their heart failure, that we would see savings. And so in our program with the MSSP, we brought in and we're focusing really on the independent physician, the small onesie twosie practices, the practices that had 4 to 6 physicians. We were focusing on them because we recognized they did not have the administrative wherewithal. And by coming together, we could collaborate, we could centralize the administration in terms of reporting. And so the other thing that was really attractive to them, there was no upfront costs. And so we offered contracts, participation contracts, and we promised them that if you came with us, we were going to do your reporting. We were going to help you coordinate your care. We were going to share data with you that would help you make better decisions about the patients that you saw. Ultimately, CV CHIP had 3 regions in the state of Virginia, but we also were in the northeast part of North Carolina. And after 3.5 years, we saved Medicare $14.8 million, and 7.5 of that was awarded to CV CHIP. So it was a real success story. It was a Cinderella story, to tell the truth, because most of the doctors didn't believe it, and a lot of people outside of CV CHIP didn't believe that we could do it. But I had confidence not only in myself, but also in my colleagues who I knew cared for their patients and, given the right information, would do the right thing. And ultimately, we did. There's another slide here. So while we're starting Jericho Reach, we were successful in the MSSP program, but as Jack has alluded to, we were only managing the Medicare Part B. Here we get an opportunity to break down the walls between the payer, which is Medicare, the physicians, and even the patients, because the patients will also come out better in this model. We will be able to provide beneficiary incentives to better manage their chronic care, also preventative medicine incentives similar to the Medicare Advantage. Also, we will have incentives for the physicians. So if you have a special program that you are doing with your patients that has shown some benefit, we can also develop those system-wide. The other thing that is very intriguing to me, I have been in practice for a long time, I will get off that 15-minute treadmill. I mean, we literally, in this fee-for-service system that we have to churn patients through. We have to focus on volume. At the end of the day, we are focusing more on how many patients did I see, but not how many patients I helped. And that is not why we went into medicine. We went into medicine so that we could be independent. We went into medicine so we could provide care for the patients. And at the end of the day, feel that we have accomplished what we started out to do. And so we will get off the 15-minute treadmill. We will hopefully, by increasing the remuneration for the work that we do, remain independent and have a better lifestyle and truly bring back the joy of medicine, what I call taking care of patients and hear my patients say to me, it's not about the money. Hearing my patients say to me, Dr. Joseph, you helped me. You helped me. I feel better. I'm grateful that you have taken the time with me to help me. And so this is part of the reason we're starting Jericho Reach. This is why we're jumping into this, because we realize we have the tools to do it. We have the desire to do it. And it's not only going to benefit us, but it will benefit our patients. And on this slide, you just see all the reasons why this model makes sense. It's going to be physician-owned and physician-governed. 75% of our board has to be the practicing physicians. We can maintain our independence. In this model, it is a capitated model. So we'll have a steady stream of income, unlike what we saw during the pandemic when many doctors literally closed their doors. There are various estimates. I think about 40,000 doctors left private practice during the pandemic. That is a serious drain on our medical economy. It's a serious drain on the ability for us to provide the care that our patients need. So all of these highlights here that you see, this is what we have built into this model. It's a physician-owned, physician-governed model. We will have a medical management services organization that will support us in the administrative aspect of the program, but they will be reporting to us. We will not be reporting to administrators. And that is one of the benefits that I see in being able to stand this model up. So Jeff is going to give you an example of what it looks like to be Medicare, traditional Medicare A and B reimbursement, what it looks like in Jericho, and what it looks like with other ACOs. Jeff?
Yep. So this slide, I think, says it all in terms of the economics. I'm going to go to the middle row, or just above the middle row, the 500, because most people on this call are probably in the 500 or above attributable lives. These are your Medicare fee-for-service beneficiaries. In the REACH program, these would be in your program. Today, on that same 500 attributable lives, you would capture, if you look at the second column, right in the middle, you'd capture about $150,000 in Part B revenue for that patient population. Maybe a little bit more, maybe a little bit less, but that's about how much. It's around 2.5% of the total cost of care is what the individual physician represents in terms of participation in their patient's total cost. The next row, the next column is the REACH benchmark. Under the REACH program, that same 500 patients would represent about $6 million in, we'll call it insurance product, that you would be in total control of, okay? In that program, instead of you managing the 2.5%, you manage the whole program. You would be in control. You take your seat at the head of the table, and the decisions that are made for those patients are under your responsibility, meaning that you control that. You decide who your partners are. The patients can still go wherever they want, but that $6 million, if there are conditions, for instance, that you could service in a lower cost home and community-based setting, you can service them wherever that patient needs service. And as long as it's the right, as long as your care is as good or better and the patient is satisfied, the difference on that is what you would get to keep. And the final column on the right is where the program nets. So on that same patients, we have 500 patients, you'd collect $150,000 in Part B revenue. In the Jericho REACH program, you would collect an additional $900,000 for that patient population. That's the difference. That's the difference between fee-for-service and advanced payment models. And there's an additional thought on this as well, and that is the difference between Jericho REACH and fee-for-service you see here. But then the next thing is, if you were to join or stay in Medicare shared savings programs, somewhere between half and maybe 70% would be retained by the physicians and the balance would go to CMS. If you have an investor partner, you figure half of that is going to go to your investor partner. If the health system controls it, the health system will decide how much you get. You know how that works out. And if the insurance companies own it, it's even more favored in their direction. So this is an opportunity to look at this differently. How you perform or how your shared savings distribution has an awful lot to do with the partner that you've aligned with and the structure of that deal. So I want to leave this up and ask if anybody on the call has any questions. I think this is a good time to go to questions. And then, feel free to drop them into chat and feel free to speak up. And
So
while
let me
you're
ask-
giving that, go ahead. While you're giving that thought, is that Dr. Michelle? Go ahead.
Yeah, I have a question here. You say for the fee, I guess Part B, fee for service, and it's an additional 900 and on top of that, that's what you get. Is that what you're saying? Or
That's right. That's right.
Okay.
Well, but I think you have to add in, I'm sorry. Yeah, you have to add into that you're not just deriving savings from physician side of practice. You're deriving savings in a much larger way from the total hospital, the inpatient side of the funding, keeping people out of the hospitals, and even the pharmaceutical side, managing that better. So look, this whole program gives you a much broader opportunity to use what we know we have as physicians, which is the ability to really want to try to improve care for patients. It gives you a chance to do that. And then at the other side of it, finally, you get to benefit from it.
That's right. You move yourself to the position of captain of care and control of the total budget. And all the Part A spending, I'm sure you can look at the hospital, the patients that you have that are in the hospital, some percentage of those medical conditions that are in the hospital today could be serviced effectively in a lower cost home and community-based setting.
Yeah, like
Some of the-
40%. Like
That's
40% of everybody on the med surge ward could be with advanced home care and all of the potential stuff that we have with remote patient monitoring and home health. Most of those patients can be managed at home.
So a lot of my members have reduced hospital utilization by 50%.
Exactly.
So you think of that, what's I'm trying to remember, maybe Jeff, you'll recall the average, per diem for a Medicare patient, $12,000 or $15,000 a day in the hospital.
Yeah.
If you just kind of think about the potential here, it gets kind of giddy with the numbers. But it's hospital utilization is sort of the gold mine here. And patients don't want to be in hospitals. Nobody wants, patients in hospital except for hospitals. So it's a great
Most don't want to
opportunity.
be in the ED either, but remember, patients are paying 20% of that in Medicare.
Yeah.
They're paying 20% of those costs, so we're saving the patients a lot of money.
Absolutely.
Yeah.
So, and the other is, you really do have the opportunity to control your destiny in this. I mean, the numbers are, that's your aha moment, right? This is your chocolate and my peanut butter moment, if you will, right? This is your chance to take your seat at the head of the table, control your destiny. And listen, the hospitals and the health plans, they move to the kids table, which those are your two biggest points of friction, if you ask most doctors. And so I think, again, this is an opportunity that doesn't come along very often. And I think what's different about this is Dr. Joseph has really picked the structure that represents what her physicians and her peers and her colleagues that she's worked with have expressed as their desires to, really take back control of their practice, because most of them are just so burned out by the end of the day after they're done seeing 28 patients a day and documenting till into the hours in the evening and dealing with all the frustration. This is an opportunity to truly have a model that works for you.
So would you guys, I'm sorry.
Go ahead. Sorry. This is Dr. Milbourne. I was wondering, so this is going to be a more costly model for us to get that increased touch. Where is the additional dollars and when would the additional dollars come in to be able to manage these patients on an outpatient bed, in an outpatient way. So make sure we get that kind of high touch situation going. So we can keep those patients out of the hospital or keep them from doing, I mean, it may not even be a matter of being sick. You know, as we all know, as physicians, a lot of times those patients go into the hospital and they'll get multiple services done and admissions done, things that they could have gone home for. So how are we able to manage that high touch situation that keeps that from happening? Because we're going to need more additional help.
That's right. Embedded partners, embedded home care, an upskilled home care encounter, upgraded home care reimbursement, connected, and also every dollar that you don't spend on a hospital, or every day that a patient doesn't spend in a hospital, it's $2,500 to the bottom line.
Hey, in answer to your question, the money's paid prospectively. I mean, kick me if I'm under the table, Jeff, if I'm wrong. So this is an advanced payment of capitation,
Right.
global or whatever level of risk we pick, but it's in advance. So the cash flow's there. I mean, if you had the hypothetical situation that no patient showed up the rest of the month, all that money would go in your pocket. Now that's never going to happen. But in answer to your question, you're not waiting for 6 or 12 months to have invoices paid in arrears. It's upfront money, making it much more possible to deploy that money and other resources as you see fit. Hire another, nurse practitioner, et cetera, et cetera. So it gives a big measure of control, and in my opinion, a whole lot less financial risk, frankly.
I have a question.
You're in charge of the finances. So,
Yeah.
In terms of what you're thinking about is how to allocate that. What are you going to spend the money on? I'm working with the company. By the way, I just want to say something. I'm not in this because I'm going to be a financial partner in Jericho and make money thanks to being here. I'm here because I'm a cheerleader for doctors. That's the only reason I'm here today. And that's kind of, but I want to say is I'm working with this company in North Carolina that has 1,000 nurses, and they're taking care of hundreds of thousands of patients at home with all kinds of sophisticated remote monitoring. And they're charging like less than $5 per member per month to constantly 24/7, 365, see what's going on with the patients that really are at risk of going into a hospital or the nursing home or wherever, assisted living. So the family and the patient decides they want this benefit, they want to stay home. This is the kind of thing we can be doing today together, but not if we try to follow the insurance rules or just the traditional Medicare rules.
My second question I have is, and if a member joins you that is a traditional Medicare member, when is his life attributed to your profile?
You sign up by August 4th. On January 1st, if you sign the participation agreement by December 31st, then on January 1st, all your attributable beneficiaries, meaning the beneficiaries that receive a plurality of services or total cost, would be your responsibility. They would be in your program.
Okay. But what if for new members? What if for a patient that says, oh, my aunt says she's in this program, she likes it, I want to join in this program?
Yes, that's voluntary enrollment. And that when you sign them in, the following quarter, they would begin to, they would be aligned with you.
Okay.
All right.
So I have a question from Crystal who wants to know the requirements for joining, who can join. And it's if you are a licensed Medicare provider receiving payments for Part A and B, and you have beneficiaries in your pool that would align to you, then you can join.
Yeah.
You can also join as a preferred provider and work closely with the ACO if you don't meet that criteria. Does that answer your question?
Yes, thank you.
Okay.
I wasn't sure if you could hear me because I wasn't, things are not so good on my phone. I'm using my phone.
Yeah, no, we hear you. Great, thank you.
Well, the reason I'm asking because I'm a nurse practitioner who came into owning a practice. Somebody gave me one. So I don't know what to do with it. So I'm trying to, and most of 200 other patients are Medicare.
Those.
Crystal,
Go ahead.
if you want to take that, or
You go ahead. No, this is your show.
So Crystal, what I would suggest is that you have a conversation with this physician. The value that he's going to add to you taking over his practice is to sign up with Jericho Reach now. And those patients will be attributed to that TIN. I'm not sure if you're going to switch TINs, but if he joins Jericho Reach, they will be assigned to his TIN. That TIN can become what we call a legacy TIN if you go to a separate TIN, and that can be applied to your patient attribution list. So that is what I would suggest that you do at this point.
All right, thank you very much.
And Crystal, if you need help with that, you can certainly reach us offline and we'll be happy to assist you in that in whatever way we can from an advisor standpoint.
All right, thank you so much.
All right, so I have a question. So I have other, I guess, ACO Reach, I guess people trying to get through, approach me. How do I know the number you gave me, guys? I received a letter. I believe I have it here that says what, given the number of, my practice, given the number of Medicare patient, this is the estimation. And, some other people give us some estimation. What, the two questions I have is how accurate is, well, I guess it's an estimation. It cannot be, I'm trying to find out, whether the number you give me, which number is really I should go with. And the other thing is which year data did you guys pull up?
So we used 2019 data.
Okay.
And what we did was we estimated, we looked at HCPCS codes, we looked at cost by setting, we looked at the admissions per thousand, we looked at a bunch of data, and we created a return on risk calculator that identifies what we'll call for this conversation shoppable DRGs. Those are pneumonia, urinary tract infections, cellulitis, UTIs, and others. And we put together a formula that shows utilization changes in inpatient admissions and post-acute utilization, and a significant increase in spend on transitions of care and obviously home care, and embedding that and using more resources and more Part B services and less Part A services. And we came up with a pretty good proxy, and we've tested it with probably 100 physicians and had them put their numbers in and say, yeah, I believe that these conditions, that they are serviceable in a lower cost setting. They don't need the ICU and they don't need the operating room. And so some of it is just the economics are going to drive behavior change. If you don't send the patient to the skilled nursing facility and you give them really good support in the home, they're probably going to be just fine. And if you don't send a pneumonia case to the hospital, but you transition them effectively home with the right support, they're probably going to be okay. And if there's
and then, by the way, the patient has the choice.
That's right.
The patient can go in the hospital for the waiting bed if they want to. It's not, you're not taking the patient's choice away, but the patient would rather be home in 90% of the cases. If you can tell them with confidence that we can take care of you and we're going to monitor you there so that we're right on top of you, just like they would be in the hospital, except, you'll feel a little more comfortable.
And the patient will save $1,484. That would be their deductible.
Exactly. They will also save money.
So Dr. Mercado asked, they already signed with Kumi ACO, and do they still need to re-sign with Jericho Reach? And the answer is yeah, the Kumi is the management company and Jericho is the ACO. So you'll want to align with the ACO. So you'll need to go back to the Jericho Reach site and enroll there.
I wanted to mention something in terms of the attributions. When we started CV CHIP and I was visiting doctors and asking them to run their list with traditional Medicare, their list was always longer than what Medicare has. And the reason for that is that our traditional Medicare patients see many doctors. And sometimes they see more than one primary care doctor. And so the attributions were always lower on the Medicare end because we really didn't see that. We didn't know where our patients were going. And so this is an estimate of what your attributions will be, but we will get that information directly from Medicare. So I wanted to clear that up. And yes, nurse practitioners, independent nurse practitioners can join and they will get attributions, but nurse practitioners working in your practice will also get attributions. So it won't, unless you don't have them billing at all under their NPI, but if you have them billing under their NPI, they will get attributions as well.
Great.
So somebody joined late. Keith, will you move back to the, actually, there's, on the screen, you can see that August 4th is the deadline. So CMS imposed a really short window for us to convene and bring in providers. We've had some great responses. We've got a lot of interest. We've added 3 additional Zoom calls or Zoom town halls that we would be happy to have you rejoin and pass word to your colleagues and your peers to join. This really works best with large numbers. Physicians, as Jack likes to say, if you move in wildebeest form into the program, you will control your destiny. You'll control the total cost. And over time, you'll negate the need for the health plans to really control the budget. This puts it back into the hands of the doctors.
Yeah, so since you mentioned that, I was at the ACC, I presided over 3/4 of the members going from independent practice to working for hospitals. And that's because of the way Medicare changed the reimbursement for ancillary services. It just made sense for them. But, so Optum's buying up practices and hospitals have practices, but you folks are still out there in the marketplace. On the other hand, what you got to understand is government is the reimbursement for fee-for-service is just going to get ratcheted back year after year for all sorts of reasons. It's not the future. The viability isn't there. So fee-for-service is going to be dead at some time soon. So it's time to get empowered. It's time to do something else, and get the middlemen out of the process and have physicians take charge of the whole thing, of the care options and the financing options. And you can hire all the support people you need, but believe me, you're going to do it much more efficiently than hospitals and insurance companies and investor companies do. So this is really, this is kind of like a no-brainer. The rewards could be so much, astronomically better for doctors. On the other hand, for patients, this is going to be way better. And if you're in a community with a huge burden of chronic disease,
That's right.
and whatever, mental health, substance abuse, whatever's added on to that, this opportunity lets you deal with whatever the social determinants are and fix it to keep them out of the hospital and out of the ED. And that's how you save the money, and that's how you benefit them.
You get paid well for doing good. The other thing is, we spend a lot of time on this talking about the payment mechanism because, look, when it comes down to it, what's good for my patients, what's good for my practice, and what's good for my pocket, right? I mean, it comes down to that, and not even necessarily in that order. But we talk a lot about the money, but what we're leaving out of this is Jericho Reach has a major advantage over the other models that have gone before this ACO model, and that is the health equity plan. And moving private equity out and moving social equity into the program is really what makes this different. And what it turns out to be is the secret sauce is pushing primary care upstream to the beneficiaries that need it and spending more time with patients that need it rather than just kind of ticking the box to do transactional care and get paid for touches.
Jeff, I think the secret weapon is Dr. Joseph. She's already done it. She's committed to the right values. She's a physician of integrity. She reflects back to why did we become physicians in the first place. So anyway, you have somebody like that to lead the process who's already done a successful ACO in an inferior model. So folks, let's get this together and take medicine back.
That's
Well,
awesome.
Jack, I want everyone, all the physicians and providers on the call to know they all can do it. I
They can.
believe in them. As I said, when I started this out, I knew the type of care they would provide if they were given the right tools. So I believe they all can do it.
course
We
they
just
can.
need the right tools, the right people at the table, and we can change the way healthcare is delivered in this country.
Right. No
Well
kidding.
said, well said.
So with that, I don't see any more questions. Actually, I see one more question and then, or a comment, and then, okay, if we have questions with the application, who can we contact? So you can send your emails to Jericho at Jericho Reach. You can contact me. That's my phone number there. That's my cell phone. Pretty soon we're going to eliminate that because it's getting blown up. And so, but you can go to the website. You can contact us through Jericho Reach. You can enroll through Jericho Reach. Look, there's no commitment, there's no cost. Your commitment would be on December 31st. Between now and then, you get the chance to really have an opportunity to look at your financial formula, make sure that it makes sense, make sure that you believe that those savings are within reach. We will put together the risk infrastructure, we'll put together the back office operations, the data, the reporting, all of that. We're taking all that burden off of you. And we'd be very excited to have you join us. And Don, you were going to say something?
No, I was
Okay.
merely being a cheerleader. I
Okay.
agree with everything it said. It's
Yeah, and I would like people to just take a cell phone picture of the screen, so you'll have all the places you need to call.
yeah.
Just take a picture of the screen.
There's almost no alternative in it. When we've got 6 or 8 or whatever 10% inflation going on now and cuts to the Medicare fee schedule, original Medicare outside of REACH is dying fast.
It is.
REACH is a big opportunity, and you know you'll be an early adopter and positioning yourself well in the future for whatever other kind of risk models you care to join. So it's it's almost a no-brainer, if I can say that. Jack, you did. I'm quoting you. That's what I think.
Okay.
It really is. Okay.
Well, if there's no more questions,
What
Go
if
ahead.
you participate in primary care first
pardon me?
and primary care first, or I participate in primary care first, and there's another ACO we're allowed to do both. So we would have to terminate I guess we would have to terminate. What do I need to do if I'm joining you guys?
You would need to disconnect from the ACO that you're in.
Uh-huh.
And Go Live, I believe CMS would convert you out of primary care first into this program. Is that your understanding, Dr. Joseph, as well?
I missed that, but I would say that primary care first, you are really just controlling, again, what you do. You're not getting control of the total care of the patient. And so that would be one difference with that. And the ACO model, again, we are, some ACOs can stand up enough of the administration to begin to contract with others. But for the most part, you're managing that Part B, and you're actually waiting to see if you're going to be paid if you have achieved savings. In this model, Medicare is betting on you to save. And so they are giving you a capitated payment based on historical cost and reimbursement for primary care. So you will get a payment every month for your attributions. And if you do well, in 6 months, they will settle up. And in 12 months, they'll settle up. So I think that this model gives you the controls that you need. It's like the managed care companies coming to you and say, control where the patient's going to get their prescriptions filled. You really have no control. You can say to the patient, go to this pharmacy or go to that pharmacy, but you don't have any control. When you align with partners, such as home health companies, You will know what their caliber of care is. You can contract with them, and then you can direct your patients in that area. We don't have all those tools in the traditional MSSP model.
So and then his question was, if he's in primary care first and an ACO, what does he need to do to join Jericho?
I would suggest
Well,
that
you cannot be in
transfer out of that.
two.
Transfer
Yeah.
out and join Jericho, because it'll be too confusing to have both
No, you
models.
can't. You can't.
So you're
Can
not
I-
allowed, if I could jump
not
in,
allowed,
you're not
yes.
allowed to be in both. And that can be done through the 4i portal. So if you need help on that, just reach out to us and we can walk you through that. There is a deadline that you need to notify them. I am flipping real quickly and can't find it,
It's in
but
September. It's in
we'll help you.
September.
Okay, thanks,
So-
Jeff.
So, Mark, I'm in that situation. I'm in an ACO now that I will terminate my contract as of December 31. But I have already sent them the notification that I'm terminating my contract because I will be starting Jericho Reach January 1, 2023. If you sign up now before the deadline of August the 4th, Medicare will run all the TINs and MPIs. And if there's an overlap, they will reach out to you and say, you're in two programs, you have to make a decision. And we have to have that certified by September the 9th. So if that's what you're in now and you feel that Jericho Reach is going to be a better opportunity for you, then you should put in your termination letter to end December 31. That way you ensure that if you have any savings coming and shared savings in the ACO or the primary care first, you will get those savings as of reporting for next year. So that's the way that works.
Now, I have, that's my last question. So I know we go to my practice, our providers go to the nursing home too. And I looked for the other ACO, when I look at some member attributed to our practice, those patients are in the nursing home. Some of them are. So the question is, if we switch to you guys, I mean, a lot of time, I guess we would, I practice in North Philadelphia, so it's a high risk population. I'm not sure, how, when you guys do your calculation, would you guys want to know those patients? How would that work? I feel that sometimes when they are in the hospital, in the nursing home, we are able to manage them better, keeping them out of the hospital. But they are high risk. I'm trying to find out how would we manage them, the data, how, the analytics to take care of them.
So those patients would not attribute to you.
Okay.
So if you're in a nursing home, I know in the direct contracting program, they did not attribute to you. In this program, they probably wouldn't. You would still be paid fee for service for those patients.
Okay, I see. Okay.
Okay. Thank you so much, everyone. Hopefully you've heard what you need to hear. If you have any questions, you know how to reach us. Hopefully you'll have the opportunity to sign up and join us. Sooner helps. Once we get to a certain point, you hit the tipping point and then everybody joins. We're hoping for that. It's open to you and all of your peers. And we're really excited to get to that August 4th deadline and see our numbers.
I have another question. This is Dr. Milbourne again. I know you say, so we need to sign, it needs to be signed up with Jericho Reach by August 4th. But I noticed you have additional town hall meetings after that. If those people attend those town hall meetings, they'd just be listening to what Jericho Reach can do for them. They will have missed the point to sign up, correct?
Yeah, we don't have any after the 4th.
Oh, okay. I
The
thought it was-
4th. Yeah, none after the 4th.
Okay, all right.
We have one on the 4th, but the portal is open until 11:59.
Okay.
And I was part of a bundle payment program that was the largest in the country. We were enrolling people up until 11:59. So we'd be excited to have you join. Sooner than 11:59 would help. Okay. Thank you, everyone.
Thank you.
You.
Thank you.
Thank you. Good night.